PR depression here, particularly in V5, V6, and also in lead 2. We have diffuse ST elevation. So this is pericarditis. Turns out that oftentimes with smallpox vaccinations we see mild pericarditis or inflammation of the membrane around the heart. And this is different than an acute MI because we have ST elevation in both 1 and 2. This guy would be really unlucky if he had both his LAD and his right coronary artery occlude at the same time. That would be very rare, not unusual. I mean, it's happened if we do a left main occlusion, but you want to be thinking pericarditis. You're going to listen for a pericardial friction rub, a 3-component atrial systole, ventricular systole, and ventricular diastole. All right, you have another one here. All right. So the rate here is slow, isn't it? 48. Okay. Axis. Normal. Doc, I feel fine. I don't know why they're doing this. I want to go fly airplanes. I'm doing great. They're trying to tell me that I have a heart attack. I do my Air Force physical fitness test. I run sub 6-minute miles. I'm in great shape. Don't let them nail me here. Yeah, we do, don't we? I got one in 1. I got it in 2. I don't have chest pain, and I know you can't hear a friction rub. So sometimes this information up here is key. Because you know this guy's 26. He's buffed and tuned, 72, 188 pounds. You know, doesn't show his blood pressure, but it's okay. This guy's an athlete. This is what we call early repolarization. And these are what we call J waves here. Right here. Sometimes we see them in hypothermia. Sometimes we see them in early repolarization. This was a classic early repolarization. African-American young athlete. We get all of these changes here. This is, and he's bradycardic, consistent with high vagal tone and athlete. So, early repolarization. Okay, here we got another one. This guy's saying, you know, I'm doing fine, I feel okay. Somebody heard a paradoxically split S2 in my cardiac exam, and they decided to get an EKG on me. What do you see? What's the rate? A little slow, isn't it? What's the axis? Left axis. What are the intervals? The PR looks maybe a little long. Okay. What about the QRS? Wide. If it's wide, it's one of 3 things. What are the 3? Well, that's more than 3, but 3 basic ones. So left anterior fascicular block, LVH, or old inferior MI. But we know that this QRS is wide. So this may be another cause of left axis deviation. Not always. QRS is wide, so it's left bundle, right bundle, or non-specific IVCD. So which one is this? Goes up here, goes down here. If I turn the EKG 90 degrees clockwise, which way is V1 pointing? So what is this? Left bundle branch block, paradoxical split. It may be LVH too. He's got a little left atrial enlargement. So, but left bundle we can't always call LVH on. It's possible, but sometimes left bundle is the end stage of LVH. All right, here's another one. So you said normal rate, very good. Grab that. That's the other thing. That's in roundsmanship, right? So what you want to do when you're in rounds is you want to make certain to grab that low-hanging fruit so that intern or resident suffers after. So you say, I got my answer. It's normal rate. What's the axis? Left axis. We know the left axis, left anterior fascicular block, LVH, all the inferior MI, okay? But we know that the QRS is wide here, isn't it? So if it's wide, it's one of 3 things. Right, left, non-specific IVCD. Which one is this? We have maybe an S wave, maybe an S. We have an RSR prime here. I'm thinking that this is right bundle branch block. Now, one of you said, man, you're really missing it here, Dr. Atwood, because this looks irregular. So it's irregularly irregular. We have a right bundle branch block, bifascicular block because it's also left anterior fascicular block because of left axis. So we have the left anterior fascicle and the right bundle. So that's bifascicular block. But we also have a rhythm. Do you see P waves? Well, if you do, they're going pretty fast at about a rate of 300 or maybe a little less, 275. So this would be atrial fib or atrial flutter probably, because right here. So this is atrial flutter with variable block. Okay, good. So this is atrial flutter, variable block, bifascicular block with left anterior fascicular block and right bundle branch block. And there you have it. Nice job. Okay, I got another one here. Okay. Yeah, I'm doing fine. You know, gave up smoking. My blood pressure is fairly well controlled on, an ACE inhibitor, lisinopril, and hydrochlorothiazide, and I also take nifedipine, calcium channel blocker. They had tough time controlling it, but I seem to be doing. I'm exercising more. I occasionally feel skips in my heart. I want to try and get insurance here. Can you help me? Now you happen to work for the insurance company. Are you going to give this guy insurance, or are you going to increase his premium? Regular rate. Yeah, very good. Oh no, not quite. He's got a few extra beats, doesn't he? Very good. And the rate is normal, though, isn't it? Okay, I'll give you that. The axis? Boy, close, though, isn't it? Trying to get to the left axis. Okay, what else do you notice? The intervals look normal. Okay, because I know you're being real systematic here. Now we're going to go morphology, right? What do you think of that P wave? Remember, it's by camelback or P mitrale. M for, well, this is left atrial enlargement here, okay? So we have LAE, left atrial enlargement, borderline left axis. Okay, inverted T waves. Yeah, I've had that a long time, Doc. They told me that 10 years ago. How about that QRS? Does it look big? Some of them do. Okay, good. So we got big QRSs here, okay? Big S wave here, big R wave here. And we have the ST change. What do we call this? Laterally and in one and AVL. Call that strain pattern because it's been there for a long time. These aren't dynamic ST changes. So this is left ventricular hypertrophy. We have LAE, borderline left axis, big S in V1, big R in V5, V6, and we have a strain pattern laterally. This is LVH with repolarization abnormality. What about these QRSs? These are premature, aren't they? These are PVCs. If I look right here, there's that P wave hidden in that and sinus rhythm. So this is AV dissociation. The QRS axis with the PVC is normal axis. So it turns out that this is probably coming from his right ventricle because it's got a left bundle morphology and it's got a normal axis. So this is right ventricular outflow tract PVC, which is very advanced. Most fellows won't even get that. But this is AV dissociation. This is a nice example. Okay.
So does he get insurance, sir?
No, you didn't increase it. Well, the insurance companies know a lot about EKGs that we don't as cardiologists. You know why? It's all in the numbers. You never want to turn anybody away who wants to buy insurance, right? The key is you want to make it worthwhile for you. So you're going to up his premium. As soon as you see those PVCs and as soon as you see those ST changes, man, that premium goes up like it's rocket. Now, if you have big volts, they don't care because they know that some great athletes do fine with big volts. It's the ST changes and the PVCs on that tracing that's going to nail that patient. Okay, this guy comes in and says, yeah, I'm doing okay. I got a little nervous with this EKG. I went out and exercised. And the other day, somebody startled me and I just dropped to the floor real fast. He said I had the herky-jerky seizure motion. And I get occasional palpitations, the heart races for just moments. Kid, I fainted a few times. But I had this incredible cough. And on my chest x-ray, I have a right middle lobe pneumonia. And being a med student that I am, I gram-stained it, and I found gram-positive cocci. It looked almost like pneumococcus. I was convinced of it. Can you just give me some Levaquin, and I'm ready to call it a day? Okay, ask me some questions, or give me the interpretation of this EKG. The rate is, the axis is, okay, the intervals. Long QT, absolutely, look at that. Man, those are scary. I wouldn't want to almost let this guy out of my sight. They're so scary. Look how long that is. This is prolonged QT.
Is the machine wrong?
Well, I don't, QTC, it is. It's very, very good. Thank you.
Trust yourself.
Absolutely. What's the best thing to happen in medicine? See? So remember that you're better than any machine. They call this 329. 329 puts it right here. There's that T wave. So now watch out for your consultant. Your computer is your consultant, but you don't have to listen. You want to listen, but you don't want to necessarily follow exactly what they say. Because you want to have confidence. But this is QT prolongation. This is nervous QT prolongation. So you wouldn't put them on a quinolone or quinidine, or you wouldn't want to put them on an antihistamine or any tricyclics. So you guys are entering into this area. You want to ask them about family history, sudden death, seizures, car accidents, drownings. Because what happens when you faint when you're swimming? Right? You drown. Or when you're driving a car, you go off the road. So this is long QT, and you want to be very concerned about it. All right, this guy comes in. He says, man, my heart's been racing away. This is tough, doc. I just feel miserable. Now, electrophysiology is like dermatology. in electrophysiology, if the heart rate's fast, what do you do? Slow it down. Very good. And if it's slow, what do you do? Okay, so why is it like dermatology? If it's dry, what do you do? Wet it. And if it's wet, what do you do? Dry it. Very good. You've now mastered two major fields in medicine, derm and electrophysiology. Don't tell my colleagues that I told you. Okay, what do you see here? Fast? It's fast, isn't it? And it's regular, very good. And the QRS is wide. Okay, so now you have a wide QRS tachycardia. You have to decide, what do I do with that? So to slow it down, we can do carotid massage. We used to crush people's eyeballs until we detached their retina. We used to rub their carotids, but we found a gentle, nicer world, but with the use of adenosine. So we could give adenosine to this and see if we could slow it down or convert it. You want to monitor it. But in a person, this guy is 75 years old, hypertensive, smoking, diabetic, with a history of an old myocardial infarction, on Lasix, and Homo 2. So he has all of the substrate for what? Ventricular tachycardia. So you want to be thinking VTAC here. And it isn't diagnostic here, but it's pretty good. It's got, what's the axis? Ooh, this one is a tough one. So if it's positive in R, it's bizarre. Okay? So with a bizarre axis, this axis is one that's going way up to the opposite side, right? It's going that way. It's neither right, it's not this way, and it's not left. It's if it's negative in 1 and it's negative in F, so that means it's going, and it's positive in R, it's going from the apex of the heart, isn't it? The other way. So that favors a ventricular rhythm. Okay? It turns out that if the R prime is on this side of the RSR prime, if it's smaller than this, that favors a ventricular rhythm. Turns out that we're looking for P waves as they march through here, and I can't tell if that's a P wave that is marching through here, but I would bet that this is ventricular tachycardia given the substrate and everything. All right, good. Right, this guy comes in, he was in Iraq, got there, was playing basketball, and then he dropped to the ground, passed out, and he was sent back to launch stool over here for evaluation. What do you think? You can ask me any questions you want.
Has it ever happened before?
Oh yeah, when I was in Alaska, and it was bitter cold, shivering, the wolves were howling, the wind was howling, and the snow it was just terrible.
How was he?
He was 25. In Alaska, he was 21.
What's his ethnicity?
Caucasian. Here's my EKG, doc. What do you think? All right, you're going to do the rate first? The rate's normal, but she went right for the action, WPW. Why did you say WPW? Okay, so let's be systematic. The rate's normal, the axis is normal, the PR is short, isn't it? It's less than 3 millimeters, so it's less than 120 milliseconds. The QRS is short. No, the QRS is wide. Look, from here to here is 120 milliseconds, right? And then there is a delta wave right there. So this is Wolf-Parkinson-White pattern. But because of his symptoms of syncope, we call it Wolf-Parkinson-White syndrome. So you'd send him to an electrophysiologist where they could maybe get rid of that pathway or do further testing. So the rate is, the axis is, the intervals. Try it. It's almost normal, maybe first degree AV block. Okay? QRS is normal. QT is normal. All right, morphology. The P wave, maybe some left atrial abnormality. QRS looks pretty normal, doesn't it? What about the ST and T wave? It does. It looks kind of spiky and tall and peaked, doesn't it? So what's that mean? The T wave is like a tent for potassium. The more potassium, the bigger the T wave, the taller it is. So this is hyperkalemia, okay? If you have small T waves, really flat, and a big U wave, that's hypokalemia.
All right, nice job. Way to participate. Have fun, all right? Medicine is a great profession.